Thank you so much for the introduction and thank you for having me. I'm going to be presenting a study on transcranial pulse current stimulation and social functioning in children with autism. And I chose this study because I believe it's crucial for clinicians to consider the mental, emotional, and social aspects along with the physical aspects of health. So, to provide some context, I'll start with a brief overview on autism spectrum disorder, also abbreviated as ASD. So according to the DSM-5, the diagnostic criteria for autism spectrum disorder are the following key points. There's going to be persistent deficits in social communication and interaction across multiple contexts, and that encompasses all of the following. And this can manifest as a variety of different things, such as failure to initiate or respond to social interactions, abnormalities in eye contact or body language, or the use of gestures, lack of facial expression, and difficulties adjusting behavior to suit different social contexts or absence of interest in peers. And on the other end, there's also the restricted repetitive patterns manifested by at least two of the following, currently or by history. And these can be seen as children lining up toys or echolalia, idiosyncratic phrases, trouble with transitions, and extreme distress at small changes, and highly fixated interests. Also, for the sensory input, there can be an indifference to pain or temperature, or adverse response to specific sounds or textures, or even excessive smelling or touching of objects. And all of these symptoms have to be present in early developmental period and cause clinically significant impairment in various areas of functioning. But these symptoms might not manifest until social demands meet or exceed rather the limit capacities, or they might be masked by learned strategies in later life. So there's a number of co-occurring conditions affecting people with autism, including sleep disorders such as insomnia, parasomnias, and this can exacerbate daytime challenging behaviors and lead to caretaker burnout as well. There's also a range of neurological disorders that are seen in autism, including epilepsy, macrocephaly, hydrocephalus, cerebral palsy, and inborn abnormalities of the nervous system. Oftentimes, there are other psychiatric diagnoses concurrent with autism, such as ADHD, anxiety, OCD, and mood and conduct disorders. And these are seen in 70 to 90% of kids and adolescents with autism. And for the behavioral disorders, these can be seen as like food refusal, self-injury, aggression, other disruptive behaviors like wandering and tantrums. And in the home and community settings, this kind of complicates outcomes for individuals with ASD. And lastly, of children with ASD, about 30% will have intellectual disabilities and 30% are minimally verbal. So who is affected? According to the CDC, in 2020, about 1 in 36 kids 8 years old in the US was diagnosed with autism spectrum disorder, with the majority being boys. And it's unsure exactly why there are lower rates of ASD in females, but the proportion of girls being diagnosed has risen and continues rising over the years, which may reflect that autism manifests differently in girls or they're misdiagnosed or underdiagnosed. And although overall autism prevalence was 50% higher in white children than among Black or Hispanic children in the past, this gap is narrowing as the identification of autism is becoming more equitable. And 15 to 20% of the world's population exhibits some form of neurodivergence. And the term neurodiversity is basically used as kind of a blanket term for neurological and development conditions such as autism, ADHD, and learning disabilities to describe variations in the function of human brains. And oftentimes neurodivergent people are stigmatized or devalued, and neurodiversity embraces the concept that differences don't need to be viewed as deficits. Okay, so how does autism develop? So studies have shown genetic risk factors and environmental influences as significant contributors to the development of autism, but the exact cause is still unknown. Environmental components can contribute up to 50% of the risk variance in autism, and these factors include things such as advanced parental age, preterm birth, delivery complications, exposure to toxins, and endocrine disrupting chemicals. And the general consensus is that these symptoms are caused by impairment of neural connectivity and damaged synaptogenesis associated with abnormal functional connectivity and plasticity. Neuroimaging studies on people with autism often reveal variations, but a specific pattern of alterations consistent with ASD has yet to be identified. For their brain growth, they have an abnormal growth trajectory with early overgrowth followed by regression. And currently, there are no present medications to rectify the core symptoms of autism spectrum disorder. The management focuses mostly on controlling the comorbid psychiatric and medical conditions. The standard of care mainly encompasses a combo of behavioral therapies, which they can be expensive and time-consuming, which affects treatment adherence. And when those behavioral therapies are insufficient to kind of cover significant challenges such as aggression, self-injury, and lability, then the psychotropic medications such as antipsychotics can be considered. But these drugs come with adverse side effects. And the current interventions show variable effectiveness, so there is a need for interventions that can augment their efficacy or the development of novel treatments, which leads me to the study I'm presenting today, which focuses on examining the safety and efficacy of transcranial pulsed current stimulation, or TPCS, in social functioning in children with ASD. So what is TPCS? That is a non-invasive brain stimulation technique. It involves sending pulse currents through electrodes on the scalp into the brain, and it affects the brain through modulating connectivity, coherence, and plasticity. Prior research on TPCS. So in Singapore, the TPCS has regulatory approval for treatment of spasticity in cerebral palsy, supporting its safety in pediatric populations. The effects of TPCS in autism specifically hasn't been investigated, but studies involving TDCS, which is very similar, has shown positive effects on the core symptoms of autism. And compared to TDCS, TPCS basically can induce the neurophysiologic responses using lower intensities. So the two main hypotheses of the study is that prefrontal cerebellar TPCS combined with standard therapy would enhance social functioning in kids with autism. And the secondary hypothesis, it was proposed that TPCS would also improve sleep dysfunctions in autism. And this was proposed based on evidence linking the prefrontal and cerebellar regions to sleep regulation, as well as some previous studies showing improved sleep outcomes using similar montages such as the TDCS, as mentioned before. So this trial was a double-blind, sham-controlled randomized clinical trial across 8 medical centers in China. And participants were kids aged 3 to 14 with official autism diagnosis according to DSM-5 and IQ of at least 35. And these kids were randomized 1-to-1 to either the active TPCS or sham TPCS group. And the exclusion criteria here, basically anything that would interfere with the brain stimulation, prior obstructive sleep apnea, and the active use of the following medications. So participants received a daily 20-minute session of either the active TPCS or the sham TPCS, totaling for 20 sessions over the 4 weeks. And the electrodes were over the right cerebellar hemisphere and left dorsolateral prefrontal cortex. And there wasn't a formal blinding evaluation, but masking was achieved through ensuring that the active and sham devices in the room setup was indistinguishable. And after each TPCS session, each participant got 1 hour of standard therapy from a blinded occupational therapist. And the therapies included applied behavior analysis therapy, structured education, play-based therapy, and speech therapy. And these were rotated for each participant so that each therapy was given 5 times over the 20-session course. And these therapies constitute the routine clinical care for ASD in China, which is why they were included to kind of provide a consistent foundation for all of the participants. So the primary outcome measure was the Autism Treatment Evaluation Checklist. It was a questionnaire that includes 4 subscales: speech and language and communication, sociability, sensory and cognitive awareness, and health, physical conditions, and behavior. And higher scores indicated a higher severity of symptoms. For the secondary outcome measures, the autism behavior checklist with items across 5 subscales: sensory, social relating, body and object use, language, and social self-help. And also the higher score supporting autism diagnosis, and the childhood sleep habits questionnaire, which had 8 different domains. And again, the higher score suggested probable sleep issues. So these were the statistical analyses used for this study. Most importantly, the analyses of covariance were used to examine the difference between groups after the intervention, after accounting for baseline values, and a p-value of less than 0.05 was considered statistically significant. So moving on to the results of the study. In total, 312 participants completed the 20-session treatment and were analyzed, with 155 being in the active group and 155 being in the sham group. Majority were boys, and the average age was 5.1 years old, with most of them being around 3 to 6 years old. Regarding their baseline characteristics, I know this is a big table with a lot of numbers, but essentially there were no notable differences in the baseline demographics and clinical characteristics of the participants between groups. So they had a similar severity in social functioning and sleep disorders. After treatment, though, the active TPCS group showed a lower mean total score in the autism treatment evaluation checklist and higher score reductions compared to the sham group. And the ANCOVA indicated that this difference was statistically significant, and the improvement was driven by a significant difference in the sociability subdomain of the ATEC, while the other subdomains didn't show a significant difference. And additionally, 54.2% of the participants reached a clinically meaningful change with the ATEC total score, which was defined as at least 10% score reduction, compared with the 30.6% in the sham group. For the secondary outcome measures, the active group had lower mean total score on the autism behavior checklist and greater score reductions compared to the sham group. And ANCOVA difference indicated that this improvement was statistically significant, and it was underscored by a significant difference in the sensory subdomain of the ABC, while the other subdomains showed no significant differences. And additionally, more than twice the amount of the active participants received a clinically meaningful change compared to the sham group. For the childhood sleep habits questionnaire, the active group also had lower mean total and greater score reductions compared to the sham, and this was statistically significant, especially in the domain of daytime sleepiness, while the other subdomains didn't have significant differences. So this is just another visual representation of the results with more detail, and I highlighted the findings of the secondary outcome measures that I just covered in these red boxes. Okay, and in terms of safety, the TPCS was well tolerated by all the participants, and no adverse effects or events were reported. The mild effects were headache and temporary scalp redness, which self-resolved after the session, and nobody withdrew due to the adverse reactions. And this is just a quick visual summary of the trial and the outcome here. So ultimately, the results demonstrated that TPCS significantly enhanced social functioning, as shown by the significant post-treatment difference in ATEC mean scores, driven by a greater sociability improvement in the active group. And the observed improvement may have been due to reduction of excitability in the left dorsolateral prefrontal cortex by the cathodal TPCS. Individuals with autism are frequently reported to have an elevated excitability to inhibitory ratio in the prefrontal region. So that's kind of how that may have worked. And then similarly, autism is associated with cerebellar abnormalities and reduced frontal posterior connectivity. So the anodal TPCS over the right cerebellum may have contributed to the results by modulating dysfunctional cerebellar circuits involved in social or communicative functions, which enhances the connectivity and improves social functioning. Results also demonstrated that the TPCS significantly improved sleep in children with autism, most notably the daytime sleepiness, as aforementioned. And similarly, this might have been due to the cerebellar circuit modulation for the circuits involving rhythm and sleep processes. And for this last point here, although the TPCS reduced both the autism treatment evaluation checklists and the child sleep health questionnaire total scores, the post hoc linear regression analysis showed that improvement in sleep was not significantly associated with the improvement in social functioning, which suggests that they occurred through independent mechanisms. So the study does have some limitations. About 88.5% of the sample were kids under the age of 7, and they were not using these particular medications. And this kind of limits the generalizability of the results to older children with autism and those who do rely on these medications. And again, the study kind of lacked resources to perform the tests on changes that might have contributed to those behavioral changes. And future studies should investigate the mechanisms such as the excitatory, inhibitory ratios that kind of contribute to those effects. And long-term follow-up was not conducted due to challenges with COVID-19 restrictions at the time. But ultimately, the 20 sessions over 4 weeks of TPCS safely improved social functioning and sleep in children with autism. And these findings suggest that TPCS might serve as a viable non-pharmacologic alternative for autism management. And future phase 4 trials exploring the effectiveness in the community setting are warranted. And here are my references.